Hello everyone, welcome to micro learning program of MFM. Today I would like to talk about common steroid doses. This is part 2. As we already know that steroid is a really useful drug if we use them in the right dose, in the right time, and then in the right way. It is very useful drug in treating so many diseases. Here are some diseases that we use steroid to treat them. Today, I'm gonna talk about the steroid doses used in severe COVID-19 severe meningitis and pyogenic meningitis. Okay, let's get started. This is standardized nomenclature of steroid dose. Here we can see steroid dose from low dose, medium dose, high dose, very high dose, and pulse therapy. Pulse therapy is administrations of high steroid dose intermittently to accelerate therapeutic efficacy. In this slide, doses based on prednisolone. If we give less than or equal to 7.5 milligram prednisolone per day, it is low dose. Medium dose is greater than 7.5 milligram, but it is still less than 30 milligram per day. It is medium dose. If we give greater than or equal to 30 milligram, but it is still less than 100 milligram of prednisolone per day, it is high dose. Very high dose is giving greater than or equal to 100 milligram prednisolone per day. Pulse therapy is giving greater than or equal to 50 milligram prednisolone per day. This is the steroid dose ranging based on prednisolone, ranging from low dose to pulse therapy. This slide is about steroid dose in severe COVID-19. As we've already know that steroid is really useful in treating COVID-19 patients, especially severe COVID-19 patients. Dexamethasone has really benefits to reduce mortality. But it is more effective in patients with invasive mechanical ventilation than patients with non-invasive mechanical ventilation. Here are those. We give dexamethasone 6 milligram once a day for 10 days. If we don't have dexamethasone, we can give other form of steroids, which is equivalent to this. Here, prednisolone, 30 milligram per day. We can give 1 or 2 divided dose. If we have methylprednisolone, we can give 32 milligram per day. 1 or 2 divided dose. If we want to give hydrocortisone, we can give 160 milligram per day, 2 or 4 divided dose. This is a steroid dose used in severe COVID-19. Okay, let's keep going. I'm going to talk about steroid dose in TB meningitis. It is taken from the recent 24 edition, which is newly released in 2022. It says the use of glucocorticoids addition to anti-tuberculous therapy is still controversial. However, a recent evidence showed that it can improve mortality by giving steroids in TB meningitis, especially given early, but it's still unclear about neurological damage and other association with HIV infection or not. Here are the doses for TB meningitis. We will give steroid in TB meningitis for total 8 weeks. I want to divide these 8 weeks into two parts: the first 4 weeks and the second 4 weeks. Okay. If the patient is older than 14 years, about 14 years of age, and the patient is unconscious and cannot be orally allowed, we can give dexamethasone 0.3 to 0.4 milligram per kg per day IV for 2 weeks. And then we will switch to 0.2 milligram per kg per day IV in week 3, and then switch to 0.1 milligram per kg per day IV in week 4. This is the first 4 week, and then in the last 4 week, we will taper the drugs. We'll give 4 milligram per day orally and taper 1 milligram of daily dose each week. The total duration is approximately 8 weeks. If the patient is conscious and can be allowed orally, we can give oral prednisolone 0.5 milligram per kg up to 40 milligram per day for 4 weeks. This is for the first 4 weeks, and then we'll taper over the following 4 weeks. This is for steroid treatment in patients with TB meningitis who is over 14 years of age. If the patient is 14 or less than 14 years of age, you can give dexamethasone 0.6 milligram per kg per day IV for the first 4 weeks, followed by reducing course over the second 4 weeks. This is for unconscious patients. If the patient is orally available, we can give prednisolone 2 milligram per kg daily, maximum 60 milligram per day, 4 to 6 weeks, and then followed by tapering. This mortality benefit associated with use of adjunctive glucocorticoid therapy in patients without HIV infection. But if the patient has HIV infection, it is still not clear about the mortality benefits of using steroids in TB meningitis with HIV infection. Now, I'm gonna talk about steroid dose in bacterial meningitis. Division 24, edition 2022 says adjunctive glucocorticoid therapy is used for reducing hearing loss and neurological sequelae in both children and adults in high-income countries, but evidence does not support the use of dexamethasone in lower-income countries or where there are high rates of untreated HIV. Dose is dexamethasone 10 milligram 4 times daily for 2 to 4 days. According to 2021 up to date, early IV administrations of steroid, usually dexamethasone, can diminish the rate of hearing loss and other neurological complications. as well as mortalities in selected patients with bacterial meningitis. The efficacy of dexamethasone therapies has been reported to vary in developed and developing countries. For developed worlds and adults with suspected bacterial meningitis, bad organisms is still yet not known, but we can recommend administrations of dexamethasone. But we have to note here that dexamethasone should only be continued if the CSF cream stain or CSF blood culture can reveal Streptococcus pneumoniae. For developing world, there are some areas where there is high prevalence of HIV infection, poor nutrition, and significant delays in clinical presentation. Just like some regions in Africa. So here, there is less exploitation or benefits by using steroids in bacterial meningitis because evidence show that benefits of using steroids can get in patients without HIV infection, and we need to administer the steroids in bacterial meningitis as early as possible to get benefits from it. So here the factors IV inversion, poor nutrition, and delay clinical presentations. Due to these factors, we cannot expect benefits of using steroids here. Delays in clinical presentation results in delay in treatment. So it results in getting less benefits and maybe even no benefits from using steroids. But in developing world, there are some areas that can recommend dexamethasone under saturation, such as if the patients have bacterial meningitis confirmed by gram stain or rapid diagnostic tests, we can recommend Dexa. So generally we can say that it is reasonable to empirically administer adjuvant dexamethasone in patients with strong clinical suspicions of acute bacterial meningitis until microbiology results are available. If we can administer Dexa, here are those using bacterial meningitis. Dexamethasone should be given 15 to 20 minutes before or at the time of the antibiotic administration. This is really important before or at the time of antibiotic administration, because this is important to be able to get benefits are using steroids in treating bacterial meningitis. If we give Dexa late, we can get less benefits or even no benefits. So we have to note this boldly. Here's our 2 dose regimes. One is for developed countries and another one is for developing countries. For developed countries, the dose is 0.15 milligram per kg every 6 hours for 4 days. This is based upon the Infectious Diseases Society of America guideline. For developing world, 0.4 milligram per kg every 12 hours for 4 days. This is based upon the Vietnamese trial. As a summary here, in severe COVID-19, you can give dexamethasone 6 milligram once a day for 10 days. It really have mortality benefits. For TB meningitis, these 4 doses are for the first 4 weeks in first 4 week, and this is for the tapering of the steroids. Duration is 8 weeks. It's also have mortality benefit, but evidence show only for patient with non-HIV. For bacterial meningitis, 0.15 milligram per kg 6 hourly. This is for developed countries. 0.4 milligram per kg 12 hourly is for developing countries. Duration is 4 days. Its benefits is it can reduce deafness and neurological sequelae, and can reduce mortality in selected patients. But the data and evidence can still show it is beneficial in using developed countries. It is still unclear for developed countries that benefits. The benefits of using this is sure or not. We cannot say clearly yet. That's all. Let's call it a day. Thank you so much for your attention. Have a nice day. See you later.